medcram.com.
Welcome to another MedCram COVID-19 update. This is number 99, and today we're going to talk about something that, well, many of you have wanted to talk about for a long time, and that's the COVID-19 long haulers. The long haulers are those that still have symptoms weeks, maybe even months after they have, quote, recovered from the acute infection of coronavirus. You may have noticed here on Worldometer when we look at a specific country, in this case the United States, we have the total number of coronavirus cases that we've been focusing on. And of course, we've been paying a lot of attention to the deaths. But the one thing that we kind of look at and pass over is the number that have recovered. And really, what does that mean to recover? And I think we're going to see here a little bit more definition. We've been holding off on this topic because we've been waiting for some data that we can actually talk about. And I think we actually have some data now in terms of these long haulers. So let's talk about them. So there was a research letter published in the JAMA Network, which we will give a link to in the description below, about these persistent symptoms in patients after acute COVID-19. Now, this study came out from Italy, specifically Rome, where they set up a post-infection clinic to look after these patients, and they summarized their symptoms in an electronic medical record. And the results were published here. So what they did was they had to have 3 characteristics in order to get into the study. Number 1, no fever for 3 days. Number 2 is improvement in symptoms. And then finally, 2 times testing 24 hours apart, negative. And what they did was they asked them to rate a number of symptoms on a scale of 0 to 100, 0 being the worst they could possibly imagine being, and 100 being the best they can possibly imagine being, both acutely, when they had retrospectively looked back and remembered how the virus was in the acute phase, and then, of course, presently, when they were following up in their clinic and at the time that they were being asked the questionnaire. So the current symptoms were what was happening weeks, months later, and they had to remember how things were when they first had the infection. So they got 179 of these people together and eventually ended up actually testing only 143 because some dropped out because either they refused to engage in the study or they were still testing positive. And what were the characteristics? Well, the mean age of these people was 56 years of age, and 63% of them were men. In terms of those who got pneumonia, 73% of them got pneumonia. The average length of stay, believe it or not, was 2 weeks, which sounds like a lot, but in some of these COVID patients, you'd be surprised. And the average BMI, and this is Italy, of course, was 26. And when they asked these people, okay, look back and tell us when did you actually have symptoms? Well, the average amount of time that it was from when they were answering the questionnaire to when they actually had symptoms was 2 months. That's a pretty long time. And so when they asked them that, they asked them a number of different types of symptoms that are pretty congruent with COVID-19, like chest pain, shortness of breath, fatigue, etc., etc. And they grouped it up. How many of you have 0 symptoms? How many of you have still 1 to 2 symptoms? Or how many of you still have 3 or more symptoms? As it turns out, 13% only said they had no more symptoms after 2 months. 32% still had at least 1 to 2 symptoms, and that leaves 55% of those that they questioned still had 3 or even more symptoms 2 months out. So the majority of the people who recovered from COVID-19, even after 2 months, still had 3 or more of the symptoms that they had at the very beginning. So these long haulers are actually not the minority, as it might turn out, at least at 2 months of time. Then they looked at quality of life, and they said, has your quality of life gotten better or worse since then? And they said 44%, according to the study, had gotten worse. And this graph from the publication really says quite a bit. It talks about the number of patients that actually had these symptoms in terms of percent, Here in the dark color, we see the percentage of those that had the acute symptoms, whereas over on this side, we have those that still have some of these symptoms even after 2 months. And so you can see here in the acute phase, fatigue, dyspnea, cough, lack of appetite, myalgia. These things down here seem to go away after 2 months. But the things that tend to stick around are these ones up here in the northern part of the graph, if you will, and that's fatigue, dyspnea, joint pain, and chest pain, and actually even cough may still remain months after the initial infection. And quite frankly, a lot of people have actually been talking about it. There's even been support groups that have been set up. And our friends over at This Week in Virology actually have done a couple of podcasts about it where they've hosted Dr. Daniel Griffin, who's talked quite a bit about it. And he's made a couple of interesting anecdotal stories and observations. And of course, we'll link to those videos in the description below. So I'll give you the executive summary, at least to this point, that Dr. Daniel Griffin gives on This Week in Virology in those episodes. He summarizes here that the major symptoms that he's seeing in his patients is a chest heaviness, a fatigue, shortness of breath, and predominantly in patients in the morning, gets better towards the afternoon, although that's not universal. He also sees some patients with depression. He also talks about the clots, that these are associated with megakaryocytes and actual platelets, which are a little different than we would expect with the regular type of clots that don't involve as much platelets. He also opined on what he's seeing, that there might be a biphasic pattern in this virus. In other words, there's a first hit, and then the patient seems to get better, and then there's another hit. And this may also include positives and negatives on a COVID test, but more particularly with symptoms, in the symptoms that we talked about up here with chest heaviness, fatigue, shortness of breath, etc. The other thing that he's seeing that is a little bit interesting is this hair loss associated with stress, where the hair doesn't grow in as well and then it comes back in, and that's known as telogen effluvium. That's a pretty common situation in patients who are under stress, and certainly if someone had COVID-19, they would be under a lot of stress, both from a psychological standpoint, but also from a medical standpoint too. The one thing that I do want to say, and I found this to be very interesting, is anecdotally among some of his patients and other colleagues' patients, the supplement that they have found that seems to work anecdotally, of course it has not been studied and he's not advocating it necessarily, is NAC, which I found to be very exciting because we've talked about NAC here at MedCram and N-acetylcysteine. We've talked about NAC not only as a substance that can help with recharging your body's antioxidant system, glutathione peroxidase, but we've shown that because of its thiol groups, it's able to break disulfide bonds. And it's those disulfide bonds that are so important in polymerizing von Willebrand's factor, which is released with endothelial damage and the oxidative stress that we see in these patients, we believe. And to me, I find this to be very fascinating. There is, I believe, a connection between NAC and the treatment of some of these platelet-rich thromboses, both arterial and venous. We've seen the reports of the autopsies done on these patients that show 9 times as many clots, at least in the lung district, where this is higher than compared to the influenza control or the transplant control that was published in the New England Journal of Medicine. So given that, one can only think that perhaps some of these symptoms that we are seeing here in this post-viral syndrome may be the result of clots. And is it possible that the N-acetylcysteine may be breaking those up, or at least helping dissolve them more quickly? It's pure speculation. We don't know. It'll be interesting to see as this virus burns its way through the population, and as the number of patients who would be termed long haulers are lining up for treatments that might be beneficial for them, if they could do a randomized controlled trial to see whether or not NAC might help those patients. I think it's certainly worth looking at. But I got to tell you that if somebody were to come to me in my clinic and say, look, I've had documented coronavirus, I am now a number of weeks out, I've tested negative, I no longer have fevers, and I have these symptoms, I'm going to be looking for things that we know that COVID-19 does to the body because we've got good evidence. I want to cover that here briefly. Let's talk about the heart and the lung and what COVID-19 does to the heart and the lung, at least in patients who are hospitalized. So here's a great research letter published by the European Respiratory Journal, which is the flagship scientific journal of the European Respiratory Society. And basically, they're looking at patients who were discharged from the hospital who had not severe or critical cases of COVID-19 that didn't require critical care intervention. And the question is what did their pulmonary function test look like if we look at the differences in those patients? And so that's exactly what this article set out to do. Let's take a look at what their findings were. So we have mild illness patients, 24 of those, pneumonia patients, 67, severe pneumonia at 19, and then the p-value to see if there was statistical significance, and we'll look at that as we go down. And you can see, first off, one of the big things that they found that was a difference is the duration of their hospitalization. And certainly, the more severe cases are going to be in the hospital for much longer, and that's no surprise. It may also be the reason why, as we will see later, that there was more severe lung dysfunction. So if we look at spirometry, and this is where you sit down and take a deep breath in and blow out as hard as you can, something can be observed called the forced vital capacity. That is the volume of air that you can take a deep breath in and blow out as hard as you can, and it's measured. And as you can see there wasn't much difference between any of those measurements, as there's the p-value of 0.63. As you go down this list, you can see that for the most part, really not much difference in any of these. The FEV1 is simply the same maneuver, but how much of that air you can blow out in the first second, and it's more of a measure of obstruction. So for those of you who are interested in learning more about pulmonary function tests and spirometry, highly recommend that you go to medcram.com, as there is a course on understanding pulmonary function tests. And this is the same course that we teach to first, second, and third year medical students. Now, as we scroll down and look at one more test here, we can see something called diffusion capacity. Now, this is very important. As I tell my medical students, the diffusion capacity is like the surface area of your lung. Whenever you see diffusion capacity or this thing called the DLCO, that's the diffusion of the lung to carbon monoxide. Don't freak out with carbon monoxide. That's just the test that we use to figure that out. I want you to think about a tennis court, because that surface area of the tennis court is about the surface area of a normal lung. And that is part and parcel of a pulmonary function test, the diffusion capacity. Now, if you notice here, there was definitely a statistically significant difference. As you can see, this p-value is very small. And notice that for the mild cases, there is a relatively good and well-preserved DLCO. And as we go further down to the severe pneumonia part, we can see that that's gone down to 64%. Now, this makes sense because typically it's in interstitial diseases, which this COVID-19 would be considered an interstitial disease after it is done, that we would see a reduction in the DLCO. The other place that we see a reduction in the DLCO, in fact, the area that we see a reduction in the DLCO in isolation from a reduction in some of these other ones, like the FVC, the FEV1 divided by the FVC ratio, is pulmonary vascular disease. So this is really important. If I were to have someone do a pulmonary function test and I were to find that all of their spirometry figures are normal, as they generally are here on this, but find that in isolation, their diffusion capacity was low, that's the kind of patient that I would be suspicious of having a pulmonary vascular problem, like pulmonary embolism or pulmonary arteriolar hypertension. And isn't it interesting that that's exactly the type of disease that we are hypothesizing that COVID-19 is? It's also, again, exciting to hear that another physician independently is hearing that N-acetylcysteine might be helpful in some of these patients. Not saying that it works for sure, but hearing that it may offer some relief, and can't help but think that that might have to do with the fact, not that N-acetylcysteine necessarily is a mucolytic, which of course it is, but that it might be working in the endovasculature and helping in terms of clots there. The other big organ that we need to talk about, of course, is the heart. And notice that a lot of these patients are having chronic fatigue, they're having shortness of breath, which can be a symptom of heart disease. And they're also having just decreased energy. And that could very well be a problem with the heart. So early on in this pandemic, it was made clear to us at a number of the hospitals that we worked at that unless we felt that it was going to change the management of the patient, we were going to limit the number of echocardiograms that we were going to do on these patients because it's difficult to sterilize the echocardiography machine, and we didn't want to expose our echo technicians to COVID-19 unnecessarily. Well, this publication bucked the trend. This is also a European publication. This is the European Society of Cardiology, and this paper was published just recently, and it's titled Global Evaluation of Echocardiography in Patients with COVID-19. And I guess where I'm going with this is that if somebody came to me post-COVID, I would definitely want to know what was their heart doing by echocardiography if they were having some of these symptoms of fatigue, especially if they were having symptoms of lower extremity swelling, shortness of breath when they laid flat. These are all symptoms of impairment of their heart. So what they found here was actually something completely unexpected. They were able to look at patients in over 69 countries across 6 continents. So this is more than a multi-centered study. This was a multi-continental study. And they looked at over 1,200 patients in a number of age groups, 70% of them male, of course, because the majority of these patients hospitalized were male. And they found that 55% of these patients that were admitted with COVID-19 had an abnormal echocardiogram. Now, we don't know if they had a normal one beforehand. Of course, we do know that these patients who get severe COVID-19 are predisposed. They already have, in other words, cardiac disease. But in this case, patients being admitted to the hospital with COVID-19 got echocardiography. 55% of those patients had an abnormal echocardiogram. And it wasn't just the left or the right. It was both sides. They said left and right ventricular abnormalities were reported in 39% and 33% of patients, respectively. Now, you would think that the majority would be left and the minority would be right, but in fact, they were close to being on par. That doesn't sound too far-fetched given that there may be a lot of pulmonary thromboembolism going on. Now, in terms of actual myocardial infarction that was new, that was only seen in about 3%, myocarditis only in about 3%, and this Takotsubo, which is another whole discussion that we can have, it has to do with a very stressed heart and usually has a better prognosis because it can recover. There was about 2% of those that had Takotsubo cardiomyopathy. Now, in about 15% of patients, there was severe cardiac disease. And there were some markers that were also elevated, like natriuretic peptide and troponin, things of that nature. But the key finding that these authors wanted to make sure that everybody knew, because we weren't doing echocardiographies on these patients because we didn't think it would make a difference, is this statement here in the conclusion. Abnormalities were often unheralded, which means we didn't know that they were there unless we looked, or severe. And here's the key. Imaging changed management in 1/3 of the patients. So these authors are advocating that we shouldn't be holding back on getting echocardiography in these patients, that sometimes it actually helped the patients, and in fact, in 1/3 of the cases, changed their management. Now, I think that's valuable information, but the point that I get from this, for this topic, which of course we're talking about the long haulers, is if somebody comes to me after a diagnosis of COVID-19, especially if they were hospitalized, and they have any sort of symptoms of shortness of breath especially while laying flat, increased swelling in their legs, even if not, I mean, there are some subtle findings that you might be able to pick up on physical examination. I would be getting an echocardiogram on these patients to make sure that we're not dealing with that in these cases. Certainly, patients can have viral myocarditis, reduced ejection fractions, things of that nature. If you're having any questions about that, let me direct you again to medcram.com for our course on heart failure and understanding the different types of congestive heart failure. Okay, so let's sum up then. Long haulers, they're real. They're common. I think they're going to become more common as we see more infections. I think we need more research. We need to know more about how to work up these type of patients. I think because of the evidence that we're seeing with lung damage and heart damage in COVID-19, if somebody comes to you and you're a healthcare provider, what you want to make sure that you're not missing is some sort of underlying lung condition or heart condition. So you may want to consider, depending on what you're seeing, getting some pulmonary function tests and an echocardiogram. And in terms of what to do, we don't know. We don't have any randomized controlled trials that tells us that this is going to work for these long haulers, these people that have symptoms after they've recovered from the acute viral infection. But there seems to be some anecdotal evidence about NAC. It's tantalizing because it fits into our hypothesis that this long hauler symptom may be related to chronic thromboses. It's possible. We don't know. And what would be the dose in that case to see whether it worked? Well, I would imagine it would be similar to the dose that they used back in the 1998 study where they looked at influenza, which, by the way, let's face it, there are some patients that get very similar symptoms, chest tightness, fatigue, shortness of breath, after they get the regular flu. And so is it possible that these two are similar in this sense, this post-viral syndrome? Well, the reason why that's important is because in that study that we've cited multiple times, that patients who were taking N-acetylcysteine at 600 milligrams twice a day for 6 months, even though they had the same number of influenza infections as the placebo, the symptomatology was much less. It went from 75% down to 25%. And so maybe this might work, but again, officially we don't have any randomized controlled trials to say that it's going to work. So thank you for joining us today. It's only appropriate, I think, that our long hauler episode was a little bit on the long side. It is also episode 99, which means that our next update on COVID-19 is going to be our 100th, and I think we should have something special planned for that. In the meantime, thanks for joining us, and stay safe. Please take a moment to leave a comment and subscribe to this channel if you haven't already. We'll see you next time.